Good day, doctors. Today we will discuss hypersensitivity after teeth whitening. Lecturer Makusheva Natalia Vyacheslavorovna, Department of Pediatric Dentistry and Orthodontics, Bashkir State Medical University. Goal of lecture: to study the causes and methods of prevention of dental hypersensitivity after teeth whitening. Questions of lecture. First, causes of hyperesthesia during teeth whitening. Increased sensitivity of teeth during office and home teeth whitening. Hypersensitivity treatment methods. Teeth whitening occupy a worthy place, allowing the dentist in many cases to achieve the necessary result without resorting to orthopedic care and without using filling materials. However, there is always a but, and hyperesthesia after bleaching is a side effect that is very common. It is maybe when using adhesive bleaching system, overexposure, predisposing factors. This is increased sensitivity of hard tissue of teeth. Definition: hyperesthesia is an increased sensitivity of the tooth tissues to mechanical, chemical, and temperature irritants. The classification of tooth sensitivity in the case of whitening can be used the same as for standard patient treatment. So, next we're discussing dental hypersensitivity classification. Dental hypersensitivity classification according to further. Group A, by relevance. First one, limited form, usually manifests itself in the area of individual of several teeth, more often in the presence of single carious cavities, with wedged sharp defects, and also after preparation of teeth for artificial crowns and inlays. Two, generalized form manifests itself in the area of most or all of the teeth, more often when the necks and roots of teeth are exposed in case of periodontal diseases. Pathological wear of teeth, with multiply dental caries, with multiply and progressive form of tooth erosion. Group B, by origin. First, dentin hypersensitivity associated with the loss of dental hard tissues in the area of carious cavities, arising after the preparation of tooth tissue for artificial crowns, inlays, etc. Concomitant pathological abrasion of hard tooth tissue and wedge-shaped defects, with erosion of hard dental tissues. Two, dental hyperesthesia not associated with loss of dental hard tissue. Hyperesthesia of dentin of exposed necks and roots of teeth with periodontal diseases and other periodontal diseases. Hyperesthesia of dentin of intact teeth, functional hyperesthesia, accompanying general disorders in the body. Group C. According to the clinical course. Grade 1. Tooth tissue react to temperature, cold and hot stimulus, and the threshold of dentin electroexcitability is 5 to 8 microampere. Grade 2. Tooth tissue react on temperature and chemical, salty, sweet, sour, bitter irritants. The threshold of electroexcitability of dentin is from 3 to 5 microampere. Grade 3. Tooth tissue react to all types of stimuli, including tactile. The threshold of electroexcitability of dentin reacts from 1.5 to 3.5 microampere. Dedova and Salamevich divided dentin hypersensitivity by the form, tooth topography, prevalence, and course of the disease, and severity. So, the form with the loss of hard tooth tissues and without loss of hard tooth tissues. Hypersensitivity depending on tooth topography, crown, neck, and root. This is the second form of dividing from classification by Dedova and Salamevich. The third form, depending on prevalence, in the area of one tooth, in the area of several teeth, in the area of all teeth. Dentin hypersensitivity depending on course of the diseases, compensated, subcompensated, and decompensated dentin hypersensitivity. dentin hypersensitivity, depending on severity: easy, average, heavy. Establishing diagnosis. Diagnosis of dentin sensitivity is based on the data from subjective and objective research methods. Subjective methods are complaints and medical history. Tooth sensitivity complaints are not always true. It very often happens that a patient has caries or a wedge-sharp defect that begins to give pain after teeth whitening. Therefore, it is necessary to resort to objective examination methods. Objective method divided to basic and additional. Basic methods are inspection, sounding, percussion. Objective additional methods are thermometry, electro-odontometry, staining dentin with days, etc. So, we have a special method for establishing diagnosis. For example, is biochemical examination of the oral fluid, spectrocalorimetry, study of the mineral composition of hard tissue of teeth, biopsy of dentin hard tissue, scanning electron microscopy, and microradiography. Recently, methods for studying pain in patients with dentin sensitivity have found wide practical application. Initially, questionnaires were proposed for this. Subsequently, pain scales were introduced. They are simpler and more efficient in solving the problem. 3 types of design of such a scale have been developed. First one is verbal type of rating scale. It has the following levels: no pain, mild discomfort, moderate pain, severe pain, unbearable pain. The next type of scale is numerical rating scale. Schematic type of rating scale. Its levels range from no pain to most severe pain. Visual analog scale is a visual type of rating scale. Scales are calculated in points. More and more researchers are now using the visual analog scale and the digital rating scale. Thus, it is possible to determine the initial level of dental sensitivity, the particular stimulus, and its dynamic during treatment. To assess the sensitivity of dentin, several methods of measuring the level of pain are commonly used. Various methods for measuring dentin sensitivity are based on detecting pain response to thermal stimuli, cold, hot, when determining sensitivity to cold water of various temperatures in use from 0 to 25, warm, heated, gutta percha. Tactical stimuli. To identify tactical sensitivity, the sensing method and its varieties are used. For example, probing with a dental probe, probing with a special probe EPL with different pressure straight. Appropriate irritants with air from a dental gun booster and at angle of 90 from a distance of 1 centimeter for 1 second. Direct an air stream to the test tooth. Other teeth are isolated by fingers. Direct air stream or lateral air jet at an angle. Electrodontometry is an examination method that allows you to check and assess the viability of dental tissues by electric current in case of their traumatic injury, neoplasm, inflammation, or other diseases of the dentition. The technique is based on the ability of dental tissue to become agitated by an external stimulus. The same tissues, based on their functional state at the time of diagnosis, have different excitability. Nerve response in the pulp conduct electrical current well. Electroexcitability changes based on the state of the nervous and vascular tissue. The conclusion about the index of excitability is made on the basis of the applied stimulation force, which is sufficient to fix the response from the tissues. For this, the minimum indicator of the intensity of irritation is determined. Affected pulp tissue are characterized by low electrical excitability in contact to healthy ones. A weak reaction is noted with pulpites, deep caries, periodontitis, neoplasms, resorption of the root structure of milk units. Very low or no reaction is characteristic of erupting elements with an incompletely formed root system. A very high reaction is characteristic of dentin hyperesthesia. For example, healthy teeth respond to current at from 2 to 6 microampere. With pulpitis, this indicator is in a range from 8 to 90 microampere. With periodontitis is reached from 100 to 120 microampere. With dentin hyperesthesia, electroexcitability can be at 1 microampere. Thus, this is one of the effective methods for the differential diagnosis of pulpitis from hyperesthesia. Chemical osmotic irritants are formed from hypertonic solution of glucose or sucrose. Previously, various acidic solutions were used for this purpose, but due to their low pH level, they provoked the development of demineralization of the dental tubules. The action of chemical stimuli is based on a change in osmotic pressure, which provoked the movement of fluid inside the dental tubulus. The solution is applied of the tooth using a cotton roll-like applicator. However, given that it is rather difficult to objectively assess the response of a tooth with this approach, most researchers have concluded that the validity of this method is very limited. And all of your favorite indexes. Tooth Sensitivity Prevalence Index by Storino. This index is determined on the basis of complaints and clinical examination. For this purpose, it is necessary to examine the patient in a dental chair using a conventional set of dental instruments and assess the condition of all teeth. The index is calculated according to the following formula. Sum of teeth with sensitivity divided to sum of teeth in a given patient, and all of it multiplied by 100%. Interpretation. With an index value of 3.1 to 25%, the prevalence of dental hypersensitivity is considered localized, and if it more, it generalized. The authors found that generalized dental sensitivity occurs in 65–48% of cases, localized in 32 to 35% of cases. Index of intensity of tooth sensitivity. The index is calculated in points and it is named based on the following indicators. 1 point. The presence of sensitivity only to temperature stimuli. 2 points. The presence of sensitivity to temperature and chemical irritants. 3 points. The presence of sensitivity to temperature, chemical and mechanical stimuli. The index of the intensity of tooth sensitivity is calculated by the formula. Sum of index values of each tooth divided on number of teeth with increased sensitivity. And interpretation. First degree hyperesthesia sensitivity, second degree and third degree. To assess the state of tooth sensitivity in dynamics, the tooth sensitivity index of Orekhova and Ulitovsky is used. This index makes it possible to trace the change in the condition of the teeth under the influence of the used desensitive means, including hygienic ones. Among the parameters of the proposed index are anamnestic indicators, that is, the patient's complaints about different sensitivity of the teeth, and professional indicators, among which the threshold sensitivity from various stimuli is measured. The degree of sensitivity is measured in points. In addition, the points measure the condition of the tissue of the teeth, the degree of gum recession, and diagnostic tests, probing and thermometry. The index is calculated by the formula, the sum of the scores of all criteria, the number of points, divided by the number of criteria and multiply by 100. Evaluation criteria for the Orekhovo-Litovsky tooth sensitivity index. Very serious condition. Serious condition. Relatively compensated state of the average degree of tooth sensitivity. The state is compensated, but against the background of the excising compensated mild degree of tooth sensitivity. A healthy tooth group of teeth with normal, natural sensitivity to external stimuli. The same authors proposed another index that allows studying the state of tooth sensitivity in dynamics. This is especially important under the influence of dosage forms or local use of oral hygiene products. The authors of the index use a formula for calculating the effectiveness of tooth sensitivity, which they propose to calculate according to the following formula: A minus B multiplied by 100% and all this divided by A, where A is digital indicator of index TSOU, tooth sensitivity index of Orekhovo-Litovsky, determined at the first visit, and B digital indicator of this index determined at the next visit. At the same time, the authors of the index also propose evaluation criteria for the obtained result of the study of the state of sensitivity according to the sensitivity index: very low effectiveness of tooth sensitivity, low efficiency, moderate effectiveness of tooth sensitivity, high effectiveness, and very high effectiveness of treatment of tooth sensitivity. The next index is complex index of differentiated tooth sensitivity by Dedova. Another index that can differentiate sensitivity is the complex tooth sensitivity index. Modern method of tooth sensitivity don't allow assessing the sensitivity of the tooth in periodontal diseases, caries with this complication, as well as with non-carious lesions and other pathologies. In this regard, a complex index of differentiated tooth sensitivity has been proposed, which makes it possible to objectively determine the degree of severity of tooth sensitivity in each patient. The index is calculated by the formula: the sum of the index values for each tooth divided by the number of examined teeth with sensitivity. The index is expressed in points, which are assessed based on the patient's subjective sensations in response to a stimulus using a digital pain rating scale. Numerical values or interpretation. Scale range from 0 to 10 points. 0, lack of response to a stimulus. From 1 to 9, intermediate values. And 10, the most intense pain that a patient can have. To determine the index, the patient is offered to evaluate this feeling in points using a marked ruler with a scale from 0 to 10. In this case, the operator selects one of the stimuli and applies it in a research. Usually, the reaction to temperature, chemical, tactical, electrical stimuli, air, stream, etc. is taken into account. Interpretation. First degree of tooth sensitivity, second degree and third degree. The use of this index in clinical practice makes it possible to objectively determine the intensity of prevalence of tooth sensitivity in various pathological processes in the mouth, including periodontal diseases, and at the same time to evaluate the effectiveness of the corresponding therapeutic measures in specific digital terms. And remember, dentin hypersensitivity mechanism. A bit of histologies. Etiopathogenesis. Normally, dentin is tightly covered with enamel and the cement of the tooth with the gum. This protects the dentin from environmental irritants. The enamel in the cervical region is less mineralized and has less thickness, so hypersensitivity is most common in their areas. Tooth enamel is an insensitive tissue, so we are talking about the sensitivity of dentin, not tooth enamel. Dentin is composed of layers: pretubular dentin, intertubular dentin, and predentin. It near of the nervous ends from pulp. Dentin consists of a basic substance permeated by many thin dental tubules containing processes of odontoblast cells, the bodies of which are located in the pulp. Dentin tubules diverge from the pulp of the tooth to the periphery in a radial direction. The sensory mechanism of dentin is not well understood, but it is believed that there are nerve endings in the dental tubulins and outer layers of the pulp. Dentin sensitivity after teeth bleaching is due to a change in osmotic pressure in the dentin tubulus. This is exactly explained by the brainstem theory. If you don't remember this theory from the last lecture, I will repeat it for you to remember it. Dentin consists of a basic substance permeated by many thin dental tubules containing processes of odontoblast cells, the bodies of which are located in the pulp. Dentin tubules diverge from the pulp of the tooth to the periphery in a radial direction. The sensory mechanism of dentin is not well understood, but it is believed that there are nerve endings in the dental tubulins and outer layers of the pulp. Hydrodynamic theory. Dentinal tubuli as a capillary tube containing fluid or pulp transudate. It is easily displaced by air, heat, cold, probe tip, etc. The movement of fluid in the tubulus leads to a change in pressure in the dentin and, as a result, increases the activity of the nerve endings in the pulp of dental tubulus. Thus, as a result of the thinning of the enamel layer or its disappearance, dentin is exposed. Dentinal tubulus open, intracanal pressure changes, and from the external openings of the dental tubulus there is an outflow of dental fluid at an increased rate, which causes irritation of the nerve fibers. Currently, the overwhelming majority of researchers adhere to the hydrodynamic theory of the owners of the tooth hypersensitivity. Further, the tubules are dehydrated, and unprotected nerve endings react with a sharp manifestation of pain to any external influence. Restoration of intratubular pressure when the dentin tubules are closed leads to rapid elimination of pain sensitivity. The most common and severe irritant to these teeth is cold. A less pronounced reaction is noted to an increased temperature, since hot temperature stimulates a relatively slow internal movement of fluid in dentin. Possible causes of dental hyperesthesia and gingival irritation after bleaching. Adding carbapol or other thickeners. Patient return. Patients under 40 experience more side effects. Dehydrated bleaching products, carbamide peroxide chemical B products. The chemical effect of mouthguards. Whitening solution, concentration, exposure time, flavoring additives, frequency of applications, congenital hypersensitivity, patient medical status, bleach pH, patient gender. Women experience more side effects than men. Mouthguard material, kappa hardness. There are two types of hypersensitivity after bleaching. Typical sensitivity associated with hydrodynamic changes. It arises due to the fact that, together with oxidation, the lubricated layer is removed, osmosis increases. And sooting sensitivity. During bleaches, hydrogen peroxide penetrates into the pulp. Such penetration is associated with the presence of microcracks, restoration with the violation of the marginal bedding. Differential diagnosis. If hyperesthesia is primary, functional, on intact teeth, differentiating from pulpitis. Similarly, pulpitis and hyperesthesia. Similarly, sharp pain, the difficulty of identifying a diseased tooth. The diagnosis is based on the duration of the pain and the electrical excitability of the pulp. With pulpitis, pain long occurs at night. Electrical excitability over 12 microampere. With hyperesthesia, pain short-term and in any time. Electrical excitability from 2 to 6 microampere. Prevention of dental hypersensitivity. There are two principal approaches to reducing tooth hypersensitivity: sealing the mouth of the dental tuberous in order to prevent the movement of fluid, which eliminates the cause of the development of hypersensitivity, and drug defect of neurons in order to suppress the ability of pulp neurons to transmit nerve impulses, which is more symptomatic treatment. Prevention of dental hypersensitivity depending on the mechanism of development of hyperesthesia. Its treatment has three main directions. The first one, effects of the central nervous system, analgesics, sedatives, psychotherapy. Second one, local anesthetic, weakened of nerve condition. And third, local pathogenetic effect on the tooth. In the case when the patient has significant tooth sensitivity after bleaching, it is recommended to use non-steroidal anti-inflammatory drugs as anesthetic. For example, ibuprofen, ketorol, ketanol, analgin, etc. Local anesthetic weakening of nerve condition. In this case of using drugs that increase the threshold of excitability of nerve fibers, These are mainly potassium salts: chloride, nitrate, citrate. As you know, the excitability of cells is based on the ability to change the membrane potential, the potential difference between the outer and inner sides of the membrane, under the influence of an ubiquitous stimulus. The membrane potential in the resting fiber is formed mainly due to the release of a small amount of potassium ions from the cytoplasm to the outside. The driving force for the diffusion of potassium ions is the difference in potassium concentration. The content of potassium ions in the intercellular fluid is 30 times less than in the cytoplasm. When using solution with an increased content of potassium ions, its concentration gradient decreases. Fewer ions come out. The membrane potential decreases. Membrane depolarization occurs. This changes the state of the voltage-sensitive sodium channels, which play a leading role in the onset of excitation. Some of the sodium channels become insensitive to the stimulus, inactivated, and this reduces the excitability of the nerve fiber membrane. The disadvantages of the potassium nitrate: has no anti-inflammatory effect, does not cause sealing of the mouth of the dentinal tubulus, slow process, unpredictable result. Protection of tooth tissue from the effects of painful stimuli carried out in several ways: exogenous initiation of enamel and dentin remineralization with the help of mineralizing components included in hygienic pastes, rinses, application gels, etc., or professional dental products. Second, occlusion, mechanical sealing of the dentinal tubulus and the formation of a protective layer on the tooth surface in order to reduce the sensibility of nerve ending for actions of stimuli. For the purpose of occluding the dental tubulus, fluorine-containing substances are used in a relatively high concentration, 5% sodium fluoride, for example, strontium salts, hydroxyapatites, calcium phosphates, oxalates, potassium oxalate 3%, iron oxalate 7%, arginine, glutaraldehyde, and NEMA. Disadvantages of this method: gradual slow process and unpredictable result. Third method, with amorphous calcium phosphate, developed and researched to prevent enamel sensitivity by stimulating the formation of hydroxylapatite crystals. Another one is hydroxyl methylacrylate, for example, Gluma desensitizer, Aqua Prep, etc. Mechanism. Being a derivative of dentin body, that is a hydrophilic composite primer, it is easily and quickly combines with the protein of the from the dental tubulus and seals to a considerable depth. It is optimal to include endogenous support in the form of various minerals complexes in any of the schemes for the prevention of treatment of dental hypersensitivity of any etiology. Today, we have a specialized complex based on the most essential microelements, balanced precisely to activate the process of remineralization of hard dental tissue. These are chewable tablets to straight teeth. Another method of endogenous prevention can be dietary supplements with calcium or other mineral components. Their use in combination with the unknown exogenous therapy will significantly increase the effectiveness of remineralization and accordingly the quality of intense therapy. Of sensitive. Step-by-step regimen for the treatment of dental hypersensitivity. In 2001, Jacobson proposed a step-by-step regimen for the treatment of dental hypersensitivity. And the first step is thoroughly examine the patient to exclude other sources of pain and find out the cause of the pain. Restore the enamel chips and relieve residual pulpits. Step 2. Apply a toothpaste with anti-sensus properties, brushing 2 times a day for 2-4 weeks as the initial period of therapy. Step 3. Obturate the dental tubulus with professional treatment with metal oxalates, desensitizers. Step 4. Ionophoresis or electrophoresis of fluorides and or calcium. 2 weeks of application. Step 5. If conservative therapy is ineffective, fillings with composite materials or periodontal surgery, mucogingival repair, etc., should be used to close the exposed dentin root site. Step 6. If there is no effect, endodontic treatment. I suggest you remember the means of individual oral hygiene to prevent tooth sensitivity, as well as professional means and methods of mineralizing therapy and deep fluoridation.
Hygiene means for dentin hypersensitivity. Basic hygiene means to reduce hypersensitivity, the following agents are used: aimed at obturation of open dental tubules, fluorine containing sodium fluoride, aminofluoride, sodium monofluorophosphate, and to reduce the excitability of nerve endings, containing passatum salts, nitrate, chloride, strontium salts, chloride, calcium component, calcium glycerophosphate, hydroxyapatite, citrates, zinc. It should be noted that tooth-sensitive toothpastes are classified as low-abrasive toothpastes. Index of radioactive dentin abrasiveness (RDA) is from 30 to 50, or they can be gel. The ideal remedy for the problem of hypersensitivity would be one that would have the following characteristics: speed of action, prolonged effect, independence from the individual characteristics of the oral cavity, lack of side effects, pleasant taste, and safety. Unfortunately, there is no such thing yet. Examples of basic hygiene products for the sensitive teeth. Mixidol Dent Sensitive. This paste is used to treat periodontitis with increased sensitivity of teeth and gums. It contains complex and passatum nitrate. The paste is low abrasive, so the process of brushing your teeth is more comfortable and non-traumatic for the gums. It is recommended to use at least 2 times a day for 4 to 6 weeks. Oral-B Sensitive Original contains 17% hydroxyapatite, which is identical to tooth enamel and perfectly strengthens the enamel, restores the natural protection of nerve fibers, and relieves increased pain sensitivity of the teeth. Silicon dioxide is included in the paste as an abrasive in a finely dispersed form. Sensodyne. The main active ingredient in Sensodyne paste is passatum chloride. During tooth brushing, the dentinal tubules are enveloped with passatum ions, and this prevents the conduction of pain impulses along the nerve endings. Rembrandt Sensitive. It is a low abrasion whitening toothpaste with anti-caries effect for sensitive teeth. It contains passatum nitrate. It closes the sensitive nerve processes that are exposed as a result of the reduction in the thickness of the enamel and dentin. and creates a kind of protective sheath. As a toothbrush for sensitive teeth, soft bristles brushes are recommended. Additional hygiene means is rinses for sensitive teeth. Deep fluoridation. The efficacy of topical fluoride depends on the concentration of fluoride used, the frequency with which it is applied on the duration of application, the specific fluoride compound used. Classification of deep fluoridation drug. Aqueous solution, sodium fluoride 2% and stannous fluoride 8%. Fluoride gels, acidulated phosphate fluoride 1.23%. Fluoride varnishes are Durafat, Fluor Protector, Cavity Shield, Me Varnish, etc. Once more we have fluoride prophylactic pastes and restorative material containing fluoride. Aqueous solution for deep fluoridation. In order to prevent the onset and development of hypersensitivity of dental hard tissue, patients should maintain oral hygiene by following the correct brushing technique. Professional gels for deep fluoridation. Fluoride gels and foams contain a high concentration of fluoride, typically up to 20 mg on gram fluoride. Gel maybe contains sodium fluoride, amino fluoride, phosphate fluoride. The 4-minute application of fluoride gel is recommended based on studies of enamel fluoride uptake. When contact time is reduced to 1 minute, enamel fluoride uptake is significantly less. Professional varnishes for deep fluoridation. A fluoride varnish is a professionally applied adherent material. It is not intended to be permanent as a facial sealant. The purpose is to hold fluoride in close contact with the tooth for a period of time. They permit the application of high fluoride concentration in small amounts of material. Remineralizing therapy. Remineralizing therapy is a modern therapeutic and restorative technique that helps to bring the mineral composition of tooth enamel back to normal. Remineralizing mixtures are administered by application, electro and phonophoresis. Remineralizing drugs are divided into solutions and gels. You can inject 10% calcium gluconate solution and 0.2% sodium fluoride solution into the surface layer of enamel using electrophoresis or electrophoresis. Borowski layout method of remineralizing therapy. consecutively, applications are carried out with 10% calcium gluconate solution for 15 minutes, 3 times for 5 minutes, and 2% aqueous sodium fluoride solution for 3 minutes. The duration of the course is on average 15 procedures daily or every other day until the focal demineralization spots disappear or hypersensitivity of dentin is disappear. Borovsky-Volkov method remineralizing therapy. A two-component solution is used, containing of a 10% solution of calcium nitrate and 10% solution of acidic ammonium phosphate. Each of these solutions is applied sequentially for 3 minutes. During 5-7 procedures on the enamel surface and in the microscopes of the subsurface layer, a poorly soluble substance, brigade, is formed, which is the source of calcium and phosphorus ions necessary for remineralization of the decalcified enamel area. This technique is effective in the treatment of hyperesthesia of hard tooth tissues. The procedures are carried out until the hypersensitivity disappears. Remineralizing solutions for remineralizing therapy. 10% calcium gluconate solution. To carry out remineralizing therapy, a 10% solution of calcium gluconate and 0.2% sodium fluoride solution are used. Solutions alternate with each other. The introduction can be done both by application and by electrophoresis. Remadentum. Remedent, a preparation obtained from enamel bones, contains a complex of macro and micro elements necessary for the remineralizing of enamel. Approximate elemental composition: calcium, phosphorus, magnesium, potassium, sodium, chlorine, organic matter, trace elements. Remineralizing gels. Rock's Medical Minerals Remineralizing Gel. This gel is a source of calcium, phosphorus, and magnesium. It has adhesive properties and retains well on the surface of the teeth. It forms a stable film that extends the exposure time of the active ingredients, which ensures their gradual penetration into the tooth tissue. GC Tooth Muse Remineralizing Gel for remineralizing therapy. It is a water-soluble cream containing casein phosphopeptide, amorphous calcium phosphate. In the oral environment, this active component binds to biofilm, dental plaque, bacteria, hydroxyapatite, and soft tissue, delivering bioavailable calcium and phosphorus. Two-component drugs for remineralizing therapy and deep fluoridation. The principle of operation of the tool is based on the properties of active ingredients. The ability to inhibit the process of enamel demineralization, remineralization of defect with high concentration of fluoride ions, bacterial effect due to the content of cuprum ions, attachment of hydroxyapatite microcrystals to collagen with the precipitation of cuprum ions, which ensures the self-assembly of the tissue. increasing the resistance of teeth to carriers influences, which is adgivad thanks to magnesium ions. Gluftaret, two-component drug for remineralizing therapy. The Gluftaret dental kit includes a liquid and suspension. Suspension: finely dispersed calcium hydroxide in distilled water with the addition of a stabilizer. Liquid is a blue solution containing fluorine and copper ions. Diaphan fluoride, two-component drug for remineralizing therapy. The sealing liquid complex includes two liquids for primary processing. For the final, the preparation for primary treatment contains anhydrous magnesium fluoride silicate, anhydrous copper fluoride silicate, sodium fluoride, and the second composition includes highly dispersed calcium hydroxide.
Thus, the treatment of dental hyperesthesia after bleaching consists of several stages and different mechanisms of action. Knowing this, you will effectively carry out the prevention and treatment of this disease.
Thank you for the attention. This video you can see as usual.